Okay, so here we're going to talk about how the mechanism of hormone functions, especially with respect to, again, going back to regulation of hormones. We'll talk very briefly about insulin and glucagon. We've covered those quite a bit, and we'll go more into the functions of epinephrine and norepinephrine. So as we've learned, there are two major hormone receptors. One is our tyrosine kinase receptor, and this is going to be used as a growth factor, so this is what insulin would use. And then we have our heptahelical receptors, our G protein receptors, which has our trimeric G protein. And these are going to be more for our hormones. And our hormones are going to trigger the G protein receptors and then start a signal transduction pathway similar to what our tyrosine kinase will do. Different pathways, different results. Now, insulin, remember, has 5 basic categories of responses that it's going to trigger. The first is it reverses glucagon or epinephrine stimulated phosphorylation. It also is going to cause a phosphorylation cascade to stimulate other enzymes. It's going to induce or suppress some enzymes. It is an actual growth factor that stimulates protein synthesis. And it's going to stimulate glucose and amino acid transport into cells. So insulin is there to tell everybody we have enough fuel, please take it up. Now glucagon is going to trigger the formation of cyclic AMP through adenylate cyclase. Glucagon is a G protein coupled receptor. That's its receptor. It's going to activate adenylate cyclase, form cyclic AMP, which activate those protein kinase A. Kinases are going to add phosphates. pKa is going to target enzymes that have a serine motif, arginine, arginine X serine motif. And again, phosphorylation is going to activate enzymes, and phosphorylation is going to inhibit other enzymes. So in the case of glucagon, it wants to activate fuel mobilizing enzymes to break down glycogen stores, for example, and it's going to inactivate fuel building enzymes such as synthesizing glycogen. Cyclic AMP is going to be degenerated, so in order for the signaling to continue, you have to have constant glucagon signaling in the cell. Now, epinephrine, norepinephrine are going to be neurotransmitters or hormones. They are going to be stress hormones, fight or flight type hormones. These are going to have some impacts on many cells, and in different ways sometimes based on the different receptors. So the stress hormones are going to increase fuel mobilization overall, going to make your cells tap into their sources, and it's going to overall increase cardiac output. Now there are 9 different receptors for your epinephrine or epinephrine. These are the androgenic receptors of the autonomic nervous system. They have 6 alpha and 3 betas. The beta receptors are going to work through those G proteins that we've been talking about, cyclic AMP, pKa, and you're going to have different receptors on different tissues. So we're going to talk a little bit about some of these receptors. So our alpha receptors are going to be located on the arteries, and these stimulation of them by our stress signals are going to cause the arteries to constrict. And this is to increase blood pressure and increase blood returning to the heart. Now, keep in mind, skeletal muscles lack alpha receptors. They need to stay open. They don't want to be constricted. And so they stay open to use this increase in blood that's pumped back into the heart. Alpha blockers are going to cause vasodilation and can treat hypertension. So the alpha blockers are going to relieve the constriction that is being caused by the stimulation of those receptors. Now, beta receptors are going to be important for cardiac function. You have your beta 1 receptors. These are going to be located in the heart and the kidney. When they're stimulated, they're going to increase heart rate and increase the strength of contraction or contractility. Your beta 2 are going to be located in the lungs as well as other places, such as the liver, vascular smooth muscle, and skeletal muscle. And when they get stimulated, they're going to increase the heart rate increase the diameter of the bronchioles to let more air in and out, dilate the skeletal muscle vessels to receive increased blood flow. So beta 2s are making things bigger. They're expanding to get an influx of stuff into the organs that are expressing them. Now treatment, so when you have epinephrine, for example, if you have a severe allergic response, you're going to stimulate your alpha, beta 1, and beta 2 receptors. So it is an agonist for these receptors. And this is all going to lead to an increase in blood pressure, an increase in heart rate, cardiac contractility increases. You're going to have dilation of the bronchioles in the lungs and dilations of your vessels in the skeletal muscles. So what happens with histamine is histamine in an allergic response is going to cause things to shut down and close, and epinephrine is going to counter that by stimulating these receptors and having things open up. Albuterol is going to be a beta 2 agonist only, so this is going to help dilate your bronchioles, and this does it without that over reaching epinephrine approach. So your albuterol is not going to have excessive stimulation of the heart. One thing that epinephrine does when you do treat a patient with it is it takes time for the patient to be able to maintain their blood pressure because you've altered all those receptors and opened everything up. So it takes a while for everything to go back to normal. Whereas with albuterol, you don't have any of that. So it's something that patients can use to treat themselves for bronchial spasms, for minor allergic reactions and things of that. We also have beta blockers. So drugs ending in olo are going to be beta blockers. These are beta 1 antagonists. So this is going to help to decrease heart rate, contractility, and blood pressure. And so this is going to be used to decrease the chances of dysrhythmia after a heart attack.